Welcome to the podcast on atypical presentation in older adults with complex illness. This podcast was created by the University of North Carolina at Wilmington School of Nursing by Melissa Aslagi, based on content authored by Dina Gray Maselli, Anne-Marie Dowling Castronovo, and Christine Bradway, in collaboration with the University of North Carolina at Wilmington School of Nursing students. The learning objectives for this podcast are to identify imminent and urgent emergencies arising from unrecognized atypical presentation of illness and geriatric syndromes, to assess an older adult for atypical presentation of disease, describe the core components of a nursing assessment for urinary incontinence, co-contribute as an interdisciplinary team member to ethical discussions related to care of older adults experiencing atypical presentation of illness and geriatric syndromes, and to recognize stigmas associated with atypical presentation of illness and geriatric syndromes and develop counter strategies to minimize these stigmas.
Let's just get this over with. I've got a 24-year-old female in bed 1 who has urinary frequency, burning during urination, and a fever of 101. Classic UTI. Just notify the physician. Bed 2 is an 86-year-old woman who thinks that it's 1941 and that she's a nurse at Pearl Harbor. Their daughter is afraid that it's dementia, but there's no need to be concerned about her condition. Her vital signs are all within normal limits.
Okay, well, how long has she been experiencing this confusion?
I don't know. I didn't ask. She's just old, you know.
Even though the 24-year-old does sound like she has a UTI, we need to assess her further and get a urinalysis to confirm the diagnosis. And for bed 2, we need to first find out when the delirium began. You know, acute confusion can be a symptom of underlying cause, especially in older adults.
But if the patient is confused, how do we know when it began?
Well, first we need to speak with the caregiver and check her medical records. I think her daughter's in with her now, so let's go speak with her.
As our population ages, nurses must be prepared to meet the special needs of this age group. One way to do this is to consider how illness, whether acute or chronic, may present differently for the older adult. Regardless of the setting that you may work in, whether hospital-based or in the community, it's important that you're able to recognize the subtle changes that may indicate a more serious problem. Being able to recognize the range of possible symptoms cannot be overstated. Recognizing the change in status is not simply due to old age is essential when providing care to older adults. The earlier these symptoms are recognized, the earlier treatment can begin, allowing for more positive health outcomes. A prompt diagnosis and intervention can result in shorter hospital stays, fewer fatalities, and reduced rates of comorbidity from treatable geriatric syndromes. Delirium is often a part of the atypical presentation of disease associated with adverse health outcomes. But how do you know if it's an atypical presentation? There isn't a gold standard for how to recognize what atypical presentation looks like for every disease. Instead, experts in geriatrics have a handful of signs or symptoms that may be an atypical presentation for any illness. These signs and symptoms fall outside of the normal or traditional signs and symptoms associated with a particular illness. Older adults may present to the clinical setting with the traditional signs and symptoms of an illness, or may be simply experiencing a change in their appetite, a loss in their functional ability, or they may be experiencing confusion. Other nonspecific symptoms include self-neglect, falling, the development of sudden urinary incontinence, anorexia, fatigue, difficulty with their breathing, and even weight loss. Any change from the older adult's baseline status should be investigated for a possible atypical presentation of illness. Atypical presentation of illness may include vague presentation of illness, altered presentation of illness, or non-presentation of illness. Let's begin by thinking about how older adults present differently than younger populations in regards to acute illness. In the older adult, pain may not always be present or may not be very intense. Caregivers and/or family members may report subtle changes in the person's behavior, and infections may be overlooked as the presenting feature is confusion. Pain is a common complaint in younger populations for presentation of illness. Some diseases that may present without pain in the older adult include acute or chronic cardiovascular illnesses, as in a heart attack or stroke, gastrointestinal disorders, such as constipation, GI bleeds, peptic ulcer disease, and GERD, and/or diseases that affect the central nervous system. For example, in a urinary tract infection, dysuria is often the most common complaint that causes the person to seek treatment. In an older adult, pain may be absent, and what you observe is a change in their mental status, or they may suddenly become incontinent when previously continent. This type of change in status cannot be attributed to normal aging. It must be investigated. A review of a few case reports demonstrates how disease may present differently for an older adult. Pain reported was subtle, atypical, or absent among older adults with acid-related diseases of the GI tract due to medications, peptic ulcer disease, or GERD. A delay in diagnosis occurred in older women with coronary artery disease due to the atypical presentation of symptoms during the infarction. Myocardial infarction in older adults, particularly those of advanced age, can occur with vague and nonspecific symptoms, including minimal or no chest pain, no shortness of breath, or acute confusion. Atypical presentation of myocardial infarction exists for older adults of advanced age, deviating from the classic presentation seen in younger adults. Given that most myocardial events occur in the older population, it is vital to recognize these symptoms. Over 60% of myocardial infarctions occur in adults aged 65 and older, and 30% occur in those over the age of 75, making early detection key for reducing morbidity and mortality rates. In addition to differences in presentation of illness in regards to pain, older adults may also experience changes in behavior that are the first marker of a change in their condition. If an older adult has not been displaying disruptive behaviors, agitation, or anxiety, and develops this type of behavior rather suddenly, we need to look past the outward behavior to determine what underlying problem is causing this change. Oftentimes, a reversible cause can be found. In the case of this 73-year-old man, he presented with behavioral difficulties of anxiety and agitation, which without a thorough investigation were wrongfully attributed to his dementia. Medication was given for his behavioral problem when in fact the underlying issue was a physiological change in his blood pressure. This was later diagnosed as pheochromocytoma. When caring for an older adult, any sudden or abrupt changes in behavior should be investigated for a reversible cause. A physical assessment and thorough workup should be conducted in order to determine the best plan of care. Even in the presence of dementia, a sudden change in status warrants a full investigation into the cause, as the older adult may not be able to communicate their needs. This brings up another important consideration. In care settings where you may not be familiar with the person's baseline status, talking with previous care providers and family members is critical to ensuring an appropriate diagnosis is made. Another prevalent condition plaguing acute care hospitals and institutions caring for the older adult is infection. Recognizing that infection usually presents atypically among older adults, the American Geriatric Society, along with the Council of Infectious Disease Society of America, have developed evidence-based clinical practice guidelines that specify assessment and management protocol depending on the type of suspected infection. In caring for older adults, it is important to recognize that atypical presentation is common, but will occur even more in those aged 85 and older. The most vulnerable of this group are those with multiple comorbidities, those who take multiple medications, and those with cognitive or functional impairments. Extra vigilance should be given to these subgroups as they are at the greatest risk for presenting atypically in illness.
Good morning, Miss Young. Nurse Badati told me that you're having some pain when you urinate and you've been going more frequently. Is that correct?
Yeah, I feel like I have to pee all the time, and when I go, it burns. I feel like I have a fever too.
Okay, well, it sounds like you may have a urinary tract infection. We're going to check your vital signs and order a urinalysis. Miss McGee, good morning. My name is Nurse Take Care. May I come in, please?
Who? Are you a patient? Yes, do come in.
Well, thank you. How are you doing today?
Fine.
Okay, well, I'd like to take your vital signs and ask you a couple questions. Would that be all right?
Yes, it would.
The consequences of not recognizing atypical presentation directly affects the delivery of quality health care to older adults across all practice settings. Because signs and symptoms of an atypical presentation are recognizable and have been linked to potentially modifiable diseases and/or geriatric syndromes, they must be identified in the nursing assessment of an older adult on a consistent basis. The following sections discuss some measures by which nurses caring for older adults in practice can utilize the nursing process to recognize atypical presentation of disease. Detection of an atypical presentation is contingent upon several interrelated steps accomplished by a thorough nursing assessment. The first is a comprehensive but problem-focused history. Secondly, a focused physical examination. And thirdly, critical analysis of this data into a determination of whether or not an atypical presentation may exist.
Miss McGee, can you please tell me your full name?
Ethel Leota McGee.
Okay, that's great. Can you tell me today's date?
I think it's the 4th or maybe the 7th of December, 1941.
Okay, can you tell me where you are right now?
I'm in a hospital in Pearl Harbor, and can't you see how busy it is? I'm a nurse, and I need to get up and get back to my patients.
Okay.
Mama has never acted like this before. All of a sudden, she got extremely confused and started talking about Pearl Harbor and having to take care of her patients. This is not like her. Please help my mother. I don't know what to do.
Well, how long has this been going on?
I called her 3 days ago, and she seemed to be fine. But when I went to the house yesterday, she was like this, talking about 1941 and Pearl Harbor.
Are there any other changes you've noticed, like maybe pain, dizziness, or a fever?
Well, she stood up rather quickly at the house, and I had to catch her from falling. She hasn't complained of any pain and hasn't been running a fever. I just don't know what's going on.
In the history, detection of atypical presentations of disease require nurses to first modify their stated repertoire of questions asked to elicit a particular problem by thinking beyond the classic symptoms associated with a particular disease entity. This means the nurse will need to expand beyond the typical symptoms reviewed on the history to also incorporate symptoms associated with an atypical presentation of disease. Because part of any atypical presentation may include alteration in level of consciousness and/or cognitive impairment, it is very important that history taking be performed by reliable caregivers or healthcare providers who can accurately report the older adult's recent history. If the older adult is unable to report an accurate history and caregivers are absent, review of the medical record or discussion with the primary care provider can provide accurate historical detail. It is particularly important to note the onset, the duration, frequency, and other associated factors of the symptom in question, and to begin to critically analyze if this symptom might be part of an atypical presentation. Information obtained is relayed to the primary care providers for prompt intervention. Next, the physical examination rests on observing or actively looking for certain telltale signs, which may be part of an atypical presentation. This includes changes in behavior such as restlessness or agitation, anxiety, and changes in cognition. All of these signs are readily observable on physical examination. The nurse should be astute to manifestations of pain, such as facial grimacing or holding one's body. Because of the difficulties in communication afflicting patients with dementia, observations made by nurses become important in the comprehensive assessment.
Well, as nurses, we can't automatically assume that an older patient is suddenly confused due to dementia or their age. We have to assess for other causes as well. It's important to remember that just because our patients didn't present with the same symptoms, they can still have the same diagnosis.
I understand. We actually read an article in my gerontology course about atypical presentation in older adults. This definitely sounds like a case that we need to investigate further.
Based on the presenting symptoms and/or sign, the nurse caring for the older adult begins to formulate an impression of whether or not an atypical presentation exists or is likely. This requires ongoing dialogue with the primary care provider and usually more specific types of monitoring to validate the changes observed. Nursing interventions for validating signs of an atypical presentation include general measures such as more frequent vital signs. It may be necessary to take a core or rectal temperature over an oral temperature if hypothermia is suspected. Other considerations are daily intake and outputs, daily weights, and observations for pain, functional changes, and/or behavior.
Hello, is this the nurse practitioner on call? Yes, we have 2 patients on the unit that need a urine culture done. Our first patient is presenting with classic symptoms of a UTI, and the other's experiencing some acute confusion, and I'm suspecting that it's a UTI as well, so I'd just like to rule it out. Okay, thank you. Goodbye.
Relay information obtained to the primary care provider for prompt intervention. The primary care provider will determine if laboratory testing or other diagnostic procedures are required. Whenever an atypical presentation is suspected, clinical judgment will guide appropriate nursing intervention. Atypical presentation can actually be a medical emergency, as in the case of acute myocardial infarction. Therefore, time is of the essence in terms of selecting appropriate nursing interventions. Having a protocol available at a facility can assist in the step-by-step approach to interventions, which is often helpful in managing certain conditions. Priority setting is also essential. Nursing care of the older adult will need to reflect immediate versus interim versus follow-up nursing interventions, whereby all interventions are prioritized according to the medical stability of the patient and nursing judgment. Clinical practice guidelines provide useful interventions for nurses when caring for an older adult believed to have an atypical presentation, provided that these guidelines address this issue.
Well, Miss Young, the urinalysis has confirmed that you do have a UTI. We're going to start you on some antibiotics that should clear it up in a few days. Do you have any questions? Miss McGee, we have your test results back, and we found the cause of the acute confusion.
Please say Mama doesn't have dementia.
Well, the good news is that it's not early stages of dementia, and the bad news is, well, it's not even bad news. She has a urinary tract infection, and this is treated with antibiotics, which should clear up in a few days, and her confusion will subside. Do you have any questions?
No, that's such a relief to know. Thank you so much for your help.
So in review, the classic signs and symptoms often presenting atypically for illness in older adults includes acute confusion, also known as delirium, failure to eat or drink, or the absence of an appetite, developing a temperature or a fever in light of leukocytosis, lack of pain with a disease that's known to cause pain, for example, peptic ulcer disease, a functional decline, reduced mobility, generalized weakness, falling, fatigue, or urinary incontinence. Table 2 presents typical and atypical symptoms of an acute MI. The typical presentation includes substernal chest pain, radiating pain to the neck, jaw, or arm, shortness of breath or dyspnea, diaphoresis, and EKG evidence of an infarction. Atypical presentation of MI may have mild or absent pain. The older adult may be acutely confused. There may be mild or absent dyspnea. There may be no EKG evidence, or a non-Q wave infarction, or a silent MI when they're actually having a myocardial infarction. Table 3 demonstrates clinical manifestations of infection in residents of long-term care settings. The typical findings of infection are fever, cough, and yellow sputum for respiratory infections, and for pressure sore infections, there may be heat, redness, purulence, and/or skin breakdown. For conjunctivitis, we may see erythema or purulence of eye drainage. The atypical findings of infection include changes in the mental status, changes in their cognitive function, a decline in their physical functioning, for example, their inability to perform their ADLs or a new onset of incontinence, falling, or failure to cooperate in rehabilitation when they've previously been cooperative. Patients may be afebrile. They may have tachypnea or dehydration. So in conclusion, when nurses caring for older adults routinely detect and act upon important signs and symptoms associated with atypical presentation, important health outcomes can be realized. In the long run, older adults can expect to experience fewer complications and risks while also benefiting from early detection and prompt management of their conditions. If you're interested in finding more information on this topic, we invite you to visit the Hartford Institute for Geriatric Nursing website at consultgerrn.org. There you will find other resources and you can explore more geriatric topics.